Good morning, everybody. Welcome to Addressing Dementia and Cognitive Decline to Prevent Falls. This is the third in our 2025 seminar series designed to help you stay healthy and stay safe by preventing falls. It's our pleasure to be able to present these seminars because we know that preventing falls is, of course, the best cure for falls. My name is Erin Olson. I am the program specialist with the Idaho Commission on Aging, and I manage our health promotion program. I also am proud to have founded and coordinate the Falls Prevention Coalition of Idaho. I wanted to welcome you on this beautiful fall day in Idaho, and thank you for making time to learn more about how to prevent falls. Next slide, please. I know that I like to have things I can refer back to after a presentation, so I don't have to try to remember it all. We just can't possibly remember everything that we hear over an hour or so. So with that said, and to answer the most common question that we ever get, yes, a copy of the slides and a few other handouts are available for you. They are currently available right now from the content panel. If you go to the bottom toolbar in your WebEx screen, there should be a button you can click on to open the content panel to have access to that. But if not, that's okay. We don't want to worry about it at all because we will have those available for you on our website probably within a couple of days after the seminar is over as well. .gov/falls, F-A-L-L-S. So whether you get them right now or get them later, we will make sure that you have access to the slides and other resources. Next slide, please. Now, another resource that you'll have access to is a recording of the seminar. We're recording it so that you can have access to it afterwards so that you can go back and review it, which is always helpful. You'll receive a link via email when it's available, and it will also be available in a few days on our Falls Prevention channel on YouTube. And that is www.youtube.com as usual, / and then our handle is at Idaho COA. So IDAHO COA. The COA stands for Commission on Aging, if that helps. So at Idaho COA. And that is our handle not only on YouTube, but for all of our social media if you would like to follow us elsewhere as well. Please also feel free to share that video link with anybody who might benefit or be interested in the seminar. We don't mind at all if you share. As a matter of fact, we would appreciate it very much. Next slide, please. All right, now there's a lot to know about cognitive decline and dementias and falls. We have a lot to share and hope that you have a lot of questions actually. So please use the chat panel to ask your questions. When the time comes at the end, we'll make time to answer as many of your questions as we possibly can. Our resident support guru, Michelle, will pose our questions to Angela, who is our expert for today, and we will get through as many of those questions as we possibly can. Next slide, please. Okay, we never want bad things to happen, but unfortunately, especially when we work with technology, we know that sometimes bad things can happen. So it's best to have a plan and be prepared. So here's our emergency plan. Number one, if you are disconnected, just log back in the same way you got here to begin with as soon as you can, and hopefully we'll get you caught up. If not, remember we do have the recording that you'll be able to go ahead and review. If myself, Michelle, or Angela loses a connection, then whoever's left will try to go on until the other person can get back connected. We do have different ways to do that, and we'll just carry on as best we can in the meantime, and hopefully again for a short period of time. Now, if we experience those solar flares or an alien invasion of some sort, we may be required to reschedule the seminar. If that happens, we will be sure to let you know when that is rescheduled so that you can attend live, or again, we will have the recording that you can refer to. So hopefully we've got all those bases covered. Let's go to the next slide, please. I always like to have some sort of idea what to expect when I attend a lecture or presentation, and we think that you probably do as well. So today we're going to start with a brief introduction to falls, or a primer, as I like to call it. What are falls and why should we care? Kind of get us a good background there. Then we'll get to our expert guest presenter and the main topics. We'll hear about dementia and cognitive decline and falls. We'll learn what the risk factors are, and then we'll learn what kinds of things we can do to prevent falls for ourselves, for those we care about, and especially when cognitive decline is playing kind of an extra factor in that. Finally, of course, we'll take as many questions as we can, time permitting, and then we'll do a quick closing and you can be off for the rest of your Monday. Next slide, please. So, thank you for giving me a few minutes of your time to talk about falls at kind of the basic level, just so we get everybody kind of on that level playing field and we all know what a fall is and why we should care about them. Next slide, please. Okay, everybody knows what a fall is, right? Yes, we would all say that we do all know that. The reason I start with a definition isn't because we don't know what it is. It's because we need a common understanding so we can all be sure we recognize them in the same way, so that we're all talking about the same thing, as a lot of people say, apples to apples, oranges to oranges. This is mainly because people don't like to admit that we've fallen. I know I certainly don't, because usually when I fall, it's because I've done something, we'll just call it silly, not the other word that we could use, and it's a bit embarrassing, right? So for almost all of us, that's something that we don't typically like to admit. We probably can benefit ourselves from all of this information because everybody has trips and slips. And so all of this information is important for all of us to know so that we can stay healthy and safe. But importantly, for older adults, it's more than just the possibility of being embarrassed. It's usually because older adults are afraid that if people know that they've fallen, or that they have a fear of falling, that these people will somehow want to limit their activities. They'll say, well, maybe you shouldn't be out gardening if it's possible that you could trip and fall when you're out in the garden, or maybe you shouldn't do the social activities. And that's a very scary thing for people of any age, really, but especially older people, because they're afraid that they're going to lose their independence, that they're going to be limited in what they can do. In fact, more than half of people, or so to say, of older adults who have fallen, even if they have an injury, don't tell anybody. They don't tell their family members, they don't tell their doctors, and that is what we absolutely do not want to happen. So for all of us, we need to know what a fall is and what it isn't. Then we can have those conversations about what we should be telling each other and having clear communications. So just to get us a full understanding of this, on screen is a very technical definition, and people give me a hard time about this definition, but we're going to break it down. It is unintentionally moving downward, typically rapidly and freely without control, from a higher to a lower level. So there's three important parts of that definition, really, that's important for us. First, it's something we don't intend to do. Nobody intends to fall. Second, for just that short moment, and boy, it sure does seem like it happens quickly, we don't have control of our bodies. It's something that we are unable to stop. Fortunately, if we can stop it, then it's not a fall. It usually is a trip or a slip or a stumble, but not a full fall. So it's that lack of control that is an important part of this definition. third is that we end up somehow lower than where we started. Now, people get confused about this. Usually we'll be standing and walking. We usually don't fall if we're just standing still, so usually walking or some kind of movement is involved. And then we end up in a lower place. So we're upright. We could end up leaning against a wall because the wall was there and we caught ourselves on the wall. It could be that we end up on the couch, maybe sitting, maybe kind of on our side, or of course, often we end up on the floor. All of these are lower than where we started. Even if we fell into the wall, that's still lower from fully upright to leaning against the wall. So that's the important concept here, is those three elements. Now, it doesn't mean that we have to necessarily fall to the floor. Like we said, we could fall into a wall, we could fall onto a couch or a chair. Technically speaking, if we were sitting in a chair and trying to get up, we could fall from the chair to the floor as well. So it's not always from standing either, just from one position that's higher to a lower position. Okay. Now, it could be caused, like I said, by a trip or a slip, and people trip and slip. But if we can't recover from it, that's when it turns into a fall. By the way, it does not include fainting, seizures, trauma, basically any loss of consciousness. That doesn't count as a fall. Because we need to be able to communicate clearly about falls and falling, we need a clear definition, and hopefully that's what we now have, so we can more cleanly and clearly communicate with others about what a fall is and when one has happened. Next slide, please. So now that we know what a fall is, the question is, why do they matter? Why should we care about falls? And, you know, falls are multifactorial, means many things, they have many causes, basically. And Angela's going to talk more about the risk factors and the reasons for falls. So I want to take just a moment to list some of the outcomes from falls, which is not meant really, you know, to just scare you. That's not the intention. It might end up hopefully making you aware that we definitely want to prevent them, though. Falls are the #1 cause of accidental injury and death in people age 65 and older. They're also the #1 cause of traumatic brain injury across all ages. That's people younger and older. 1 in 3 older Idahoans falls at least once each year. That's 33%. 1 in 5 of those falls causes a serious injury, not just an injury, but a serious injury like broken bones, a broken hip, broken arms, broken wrists and ankles, as well as traumatic brain injuries. Nationally, over 800,000 patients are hospitalized every year because of a fall. And that statistic is actually a few years old. So my guess is that it's probably closer to 1 million people a year that are hospitalized, not just taken to the emergency room, but actually inpatient in the hospital due to a fall. Here's even the more staggering part of that, is that the average cost of a fall that requires medical attention in Idaho is $38,373 per fall. That's a lot of money, either being paid by our insurance or unfortunately many times by Medicare, Medicaid, or even out of pocket. Finally, falling once doubles your chance of falling again. And that's what we absolutely want to prevent, is that cycle. And it is a downward cycle, unfortunately, that once people fall, especially older adults, they tend to fall again and again. All of these should make us want to reduce the chance of ourselves and others falling. And that's what we're here to kind of address for the rest of our time together. Next slide, please. Now, I just want to finish with one last slide, and then we'll get on to our expert. These are Idaho-specific statistics. Most importantly, probably for us, is that 67% of falls happen at home. And I think most of us know that the highest risk is at home, especially where there are wet surfaces like in our bathrooms and our kitchens, or trying to rush to the bathroom at night and we trip over the cat or the dog in the dark hallway. 9% do happen in institutions like hospitals and clinics and places like that, but also 4.5% happen in public spaces. So what does this mean? It means we need to focus on keeping our homes safe first and foremost, and we can do that either for free or very inexpensively and fairly easily. But we also need to work to have safe public spaces and buildings, our sidewalks, our neighborhoods, and those places where we need to be out in public and also need to be free from trip and slip hazards. So next is that in Idaho, geography matters. We actually have a higher than average fall rate. Like I said, 1 in 3 older adults in Idaho falls at least once each year. The national average is only 1 in 4. So that's 25% versus our 33%. But in addition, we have some counties in Idaho that are more than 5%. The falls rate is higher, I should say, than 5% higher than the rest of the state. And those include Bannock, Bingham, and Bonneville, Elmore and Jerome, as well as Kootenai, Shoshone, and Twin Falls counties. So just, take that information for whatever it's worth. It does let us know what the risks are, as well as where these falls might occur so that we can start to take some steps to prevent them. Next slide, please. So without further ado, please let me introduce our guest speaker. Next slide. Angela is a registered occupational therapist with 23 years experience. She works in subacute rehabilitation and academia, and her work is really driven by a passion for improving the lives of others, particularly those with cognitive challenges, which is why we've asked her to be with us here today. As an educator, Angela works as an assistant professor and performs with academic fieldwork at the College of Western Idaho. She takes pride in shaping the next generation of occupational therapy professionals. And I know that sometimes, OTs can be difficult to find. So we're very thankful that she's helping promote that in our area. If that wasn't enough, Angela is currently pursuing her PhD in rehabilitation as well at ISU, Idaho State University. Her research focuses on how simple technology can assist people with dementia in performing daily tasks. So that's a fantastic tie-in that we can use technology to help people function better when they have some of these medical conditions that before we didn't have those possibilities. Angela is considered a dementia care specialist, and she holds advanced training from the Crisis Prevention Institute. Now, in her spare time, yeah, right, like she has a lot of spare time, Angela likes to spend time in the great outdoors. That's why she's in Idaho. She hikes and bikes and skis, and she likes to do those kinds of things with her family. So, ladies and gentlemen, it's my true pleasure to introduce to you Angela Zaugg and let her tell you all she can in the next hour or so with about cognitive decline and falls prevention. So take it away, Angela.
Okay, well, thank you for asking me to speak today or to present today. And thanks to Erin for that nice introduction. I'm always nervous when someone calls me an expert in anything, but I have been around for a while, so I might have learned a few tips and tricks in my years working with the older adult population. So hopefully I can share some of those things with you today and you'll find them beneficial. So my presentation today, as Erin mentioned, is looking at dementia and cognitive decline and ways that we can help that population reduce their fall risk. As a professor, I like to not scare my students, but I tell them that I'm going to start my presentations fairly often with what I call the scary statistics. And I'm not to scare them, but it's eye catching. And so when I say scary statistics, they listen. And then those numbers help us realize the magnitude of an issue. And like Erin said, why do we care? Why is it important that we have this information, and what can we do about it? So that's where I'm going to start today with you all. Like I do my students, go over the scary statistics, and again, not meaning to scare anyone, but just to catch and make you aware of how big of an issue this really is, especially in the dementia population. So as you can see there on my first slide, older adults with Alzheimer's dementia are nearly twice as likely to fall each year. So that's 44% of adults with dementia compared to only 26% of their cognitively typical counterparts that are 65 years and older. Some studies estimate that up to 60 to 80% of individuals with Alzheimer's disease fall annually. So the vast majority, which sounds kind of scary, but there are some simple things we can do to try to reduce that number. And also the problem is not a single fall event. So of those people that fall, a significant proportion of this dementia population will experience not just one fall, but multiple falls in a single year. So a recent meta-analysis of people with Alzheimer's dementia found a yearly rate of recurrent fallers, or those that experience more than one fall per year, of about 42%. So you can see this elevated fall rate as it compares to the rest of the older adult population emphasizes the need for dementia-specific fall prevention interventions. Next slide, please. So there's a cascade of consequences when it comes to these falls. So falls in individuals with dementia extends beyond just the incident rate, as I discussed in the previous slide, but it precipitates a severe cascade of health and social issues and outcomes. So not only are adults with Alzheimer's dementia more prone to falls, they also experience a greater incidence of injury after a fall, with one study reporting that 45% of fallers with Alzheimer's dementia sustain an injury. This leads to a significant increase in visits to the emergency room and hospital admissions, and you can see the percentage there. So the fallers that end up at the ER, 15%, and those with dementia that get admitted when they visit the hospital. That's compared to just 9% and 7% respectively in the older adult population without these cognitive deficits. So the long-term consequences then after this fall with injury can be severe. Falls can lead to a decline in functional status, a loss of independence, and even death. Erin mentioned some of the common fractures that occur after a fall. So, if you have a fall and it ends up, you reach out, as our reflexes are meant to do, you reach out to catch that fall, end up with what we call a fouche, or a fall in an outstretched hand, a fouche injury, which results in a Colles fracture, which is a fracture of the radius bone here. It takes the front of that fall, you fracture, you end up having that wrist pinned in surgery, and then the real work happens, right? If you're going to probably reach out with your dominant hand. That dominant hand is broken, and now I'm in a lot of pain. How do I do simple things like get dressed, feed myself, brush my teeth, all of those things? So you can see that fall, if it results in injury, can really impact someone's independence, and in worst case scenarios can even lead to death. So again, just emphasizing the need to reduce those falls, prevent those falls from happening in the first place. Older adults with Alzheimer's dementia who experience a fall are 5 times more likely to be institutionalized. That data point alone just indicates that the fall is usually a tipping point that then forces a transition from community living to being transitioned to a more long-term care environment. It's kind of a tangible event that signals to their loved ones that maybe they can't be safely managed in their current environment. What we hope to do is to continue to allow them to stay in their environment, because research shows that especially for people with dementia, they rely on their procedural memories, the things they do each and every day, over and over again. Their environment gives them cues, their familiar environment gives them cues that help them remember their routines and what they should be doing each day. And so, more than almost any other population, I really try to advocate for keeping somebody with dementia in their home as long as possible. Again, taking into consideration the demands that it places on their families and caregivers, but just recognizing that they thrive in their natural environment. We all do. So anyway, the serious implications for patient independence, the family caregiver stress, as I mentioned, the allocation of our healthcare resources. Erin mentioned, almost $40,000 when there's a fall with injury, requiring a hospital admission. There's just a significant human and financial cost. It again underscores the importance of implementing these effective prevention strategies. So we'll go to the next slide. And we want to look at, because the heightened fall risk in people with dementia is not due to a single cause, it is driven by an interplay of both internal and external risk factors. So these internal risk factors are those related to the individual's physical, cognitive, and psychological state. So we'll start at the cognitive impairments first, because that's probably the thing that most people think of when they think of people they might know who have dementia. So impairments, the biggest impairment in cognition is that of executive function. There's a lot of things that executive function does for us, including motor planning, motor control, and attention. So being able to anticipate how they navigate in their environment, to avoid obstacles, to even attend to the obstacle in their path is diminished because of that diminished executive function, and that is why their fall risk increases, one of the reasons. So they found that individuals who score lower on tests of executive function are 3 times more likely to fall in the next 2 years. So executive function can be a really good indicator of fall risk, and most people don't think of it that way. I'd like to speak to, well, I'll get to that in a minute, about the next cognitive issue that is often impacted in dementia, and that is the ability to complete what we call dual tasking. It's the ability to simultaneously perform a motor and a cognitive task, so walking and talking. And I test this often when I'm working in subacute rehab with all my folks, but especially those that might have a history of cognitive deficits. So as we're walking to the rehab gym, say for our therapy that day, I'm asking them if I want to give them a little challenge or a bigger challenge to do serial 7. So as we walk, Mr. Jones, can you subtract 7 starting at 100? That's a pretty good cognitive task. So can they do that and simultaneously walk down the hall? If I'm not feeling that mean, I'll maybe do 5, something a little simpler, but kind of based on where I think they are cognitively, I try to introduce a cognitive demand in the task of walking from their room to the gym for therapy. And it's pretty eye-opening to see how their motor planning kind of goes by the wayside. So if you think of our cognitive capacity, our cognitive reserve is like a gas tank. So if our brain's like a tank full of gas at the start of the day, and then as the demands of the day ensue, we use up a little of the gas that's in our cognitive reserve, in our cognitive gas tank. And with dementia, our reserve is smaller. And so sometimes it won't take much to kind of use up what we have in our tanks. And this dual tasking is one of those examples. So what I'll often see is that they can walk down the hall and maybe occasionally answer a question about how are you today, general questions. But if it requires kind of working memory and thinking in the moment, then they start to shuffle. They might lose their balance. They might start looking around like they've lost their way. So they choose to do one or the other. So they're conserving their cognitive reserves, and they can either walk to the gym very well, or they can stop and we can have those conversations. We can work on subtracting 5 from 100 backwards. But to do both is just too much of a demand. And so that's a quick way that you can maybe see if there is a cognitive issue that might increase someone's risk for fall. The other part that I wanted to look at is how cognition can profoundly affect how a person perceives and processes visual information. I refer to this as visual attention. So I'm not speaking about just attending to something, which is a cognitive task, but also our ability for the brain to recognize, to perceive what is in our environment. And that is, as I mentioned, pretty profoundly affected in dementia, especially in the later stages. So in a typical, and this is how I screen for that. So another simple trick you could use to kind of see if there might be potentially some underlying cognitive issues that could contribute to fall risk. So again, as I go into a client's room for their therapy at the subacute rehab facility, I'll often, one of the first things after introducing myself is to ask them to locate something in the room. Now, cognitively, a person who is cognitively intact, and I choose an item that is not in the immediate, like right immediately in front of them. It's something I think will probably be in the next room, like the bathroom. And so I walk in and ask them, hey, do you think you could get your hairbrush this morning? And somebody who is cognitively intact will not only kind of look side to side to locate that, even in a new location, like a rehab room, but they'll also then say, oh, it's probably in the bathroom, and they'll recognize that there's another room within that room, the bathroom, and they'll attempt to get up and go retrieve that item. Now, as dementia progresses, our visual attention or our ability to recognize the space that we're in decreases. So in mild dementia, you might see someone, kind of look immediately in their room, turn their head side to side, looking for that object, but they may not recognize that there are other rooms that they need to go looking for it in. As dementia progresses more to the moderate stages, they'll kind of look for what's in their periphery. They might turn their head side to side a little bit, but if it's not kind of right there in the periphery, so maybe the closet is behind them with their clothes, and I ask them to get something out of the clothes closet. If they don't see the clothes closet kind of right here in their periphery, they need some help to locate it. Now, in the later stages of dementia, that ability to perceive what's in their environment is literally just limited to what's kind of right here in front of them at arm's length. So if I ask for them to get the comb and it's not directly in front of them, they won't recognize that there's places that they could look for it. You won't see the motor behavior of looking and moving to find that object. So again, a quick screen can just be how much are they looking for an object to recognize that there might be a deficit that could impair their visual attention. So you can imagine if as dementia progresses and really all that, and that's not to say that there's anything wrong with their eyes. They might have 20/20 vision, but even though that information is coming into their eyes and going to the brain to be processed, the brain isn't processing it the same, as not able to perceive that information anymore the way it used to. And so, you can imagine if they're only seeing kind of what's immediately in front of them, that they're not even thinking about recognizing the need to anticipate an object that might be in front of them, or look down at their feet to see if there's a rug or a change from hardwood floors to carpeting. They just won't recognize that because they can't visually attend to or perceive that anymore. So again, I like to just give those little tips and tricks of information so you can maybe do a quick assessment to see if you're seeing some of those cognitive issues that you might not pick up on unless you ask them to do these specific tasks. Let's move on to the physical deficits related to those internal risk factors that might contribute to falls. So again, as we know, dementia is directly linked to mobility problems such as gait and balance abnormalities. Usually you'll see that there's just a decrease in the number of steps. So their steps are slower and they take fewer of them. So if I was going to time someone to say, how far can you walk in 1 minute? They wouldn't get as far. Their steps are slower and they're just not taking as many. So they won't get as far as that minute as those without dementia. They also experience those same declines in physical strength, muscle weakness, and even frailty that occurs as we all age. So in the older adult population in general, this just again exacerbates the issues with dementia. And then looking at the psychological factors that might contribute to falls in dementia, we're looking at mental health issues such as depression and anxiety. Those are actually fairly common in dementia, and they can lead to reduced attention, increased fatigue, reduced reaction times. And then some of the symptoms that we think of associated with dementia, the wandering, the confusion, this will impact their ability to navigate their environment safely as well. All right, let's look at the next slide at the external risk factors that might contribute to falls in people with dementia. And these are often related to the environment or medical treatment. So the good news about this is that they're very easily modifiable, more so maybe than those internal risk factors. So looking at those first might be a good way to start reducing or preventing falls in this population. So looking at polypharmacy, this one we can modify with a trip to our physician or a discussion with our pharmacist. But polypharmacy, I'm sure you've heard this term before. It's actually pretty common as we age, but the definition is anyone who is taking 4 or more prescription medications. Polypharmacy is associated with an increased fall risk. In fact, one study found that individuals who take 4 or more medications are at an 18% higher fall risk, and then those who take 10 or more is at a 50% increased fall risk. So just the act of taking multiple medications, because of the potential side effects, can increase a person's fall risk. And it relates to people with dementia because they tend to be on several medications. So they have medications to manage the symptoms of dementia, but then, as we get older, we all have, chronic conditions just happen to us as we age. So arthritis, osteoarthritis, heart disease. Almost no one can avoid heart disease as we get into, our 80s and 90s. There's just going to be loss of elasticity in our veins and arteries, and our heart isn't pumping quite as strongly. It just happens to all of us, and we're often given medications to manage those chronic conditions that are common in older adults, and that can lead to polypharmacy too. So we just want to make sure that we're only taking what we need to be taking as far as prescribed medications go, but also understanding the side effects so that we can maybe reduce those that have those side effects that will contribute to falls. And that would relate specifically to those CNS active drugs. So if we look at those that act on our central nervous systems, those are the antipsychotics, the antidepressants, benzodiazepines, which is a common anti-anxiety medication. So again, if depression and anxiety are commonly occurring within dementia, there's a good likelihood that they're on these CNS active drugs. To address that, I'm not saying that you shouldn't be on them, but just be very aware, make the doctor aware. They might not be thinking about that when you go for your doctor's visit, that these drugs do contribute to falls because of their side effects, and just to be closely monitoring anyone who is on them, especially someone with dementia. Pain medications, as we all know, like opioids, can contribute to falls because they can make us dizzy and drowsy. They can also even cause some motor impairments. So being careful of those opioids when they're prescribed in dementia, and then also some common cardiovascular medications. I mentioned that there's often a co-occurrence of heart disease as we get older, so it isn't unusual for someone to be on ACE inhibitors or beta blockers. Those are pretty common. Those are meant to address the hypertension that tends to occur as we get older. The danger with those is that they maybe work too well. So maybe rather than just reducing our hypertension, they're shifting us into hypotension or low blood pressure. And you'll see that if someone stands up from a chair, they get a sudden drop in blood pressure or dizziness, and that can lead to a fall. Looking at environmental hazards, as Erin mentioned, the majority of falls occur within the home, so we want to make sure that our homes are safe. Looking at whether we have loose rugs that we can tack down or just roll them up and remove them. Because again, in those later stages of dementia, they're not going to anticipate or even see those rugs down there at their feet. They're just not, their feet are down here and their visual attention is up here in a very small area. So just reducing that risk altogether. Looking at uneven flooring, again, those transitions between carpet and linoleum, carpet and hardwood, making sure the lighting is good, and then even letting the environment do the lighting itself. So if we don't cognitively process that we need to turn on a light, the light will come on for us. So those motion sensors, those night lights can help reduce falls. And then ultimately, I'm just looking at clutter. When I go into a home as an occupational therapist to do a home assessment, really just clearing those pathways again for that same reason, just making sure there aren't things that we catch a toe on, because we're not in dementia, we're just not going to see that they're even there and anticipate that we need to avoid them. And then finally, as far as external risk factors, we want to look at those acute illnesses. So sudden illnesses that might occur, those will contribute to a fall. The most common being a urinary tract infection. If those aren't caught, so looking for, malodor, darker urine, frequency, urgency, that might indicate a urinary tract infection or UTI. You want to make sure that those are addressed right away, that they get the treatment that they need, because that untreated UTI can lead to delirium, leads to increased restlessness, agitation. Again, it will just increase their fall risk. So prompt treatment of the underlying infection like UTI can also reduce fall risk in dementia. And then we'll move on to the next slide. Some exciting research, some more recent research that I want to point out today. One of the kind of take-home messages I give you today, if nothing else, this new research is kind of exciting in that it might help us catch people who have dementia or recognize them earlier in the disease before we even know that, or we're even seeing any cognitive issues. So this more advanced understanding of the dementia-fall relationship is the recognition that falls are not just a consequence of dementia, but may also serve as a precursor or an early indicator of impending cognitive decline. So it's a two-way street. So the typical way of thinking has been cognitive decline clearly increases the likelihood of falls, especially if that fall results in trauma or injury to the head, and that can accelerate the progression of dementia. However, this looking at the fact that falls might actually be an indicator of underlying cognitive issues, that two-way street relationship can actually help us preemptively maybe screen and assess for those who might not have obvious signs of cognitive issues yet, but these falls might be an indication that there really is something, an underlying undiagnosed neurological condition. So when I get to, the what next at the end of this presentation, we'll talk about how that knowledge can help us maybe screen for and diagnose dementia in the earlier stages of the disease, so that we can get the resources to that population that we need to. I want to talk about a large retrospective study. They looked at 2 million older adults who had had a traumatic injury, and so all types of traumatic injuries in older adults, but the relationship between falls and an underlying cognitive issue became very obvious in the study. They found that those who experienced a traumatic injury due to fall had a 21% more likely to be diagnosed with dementia within a year compared to all of the other types of injuries that may have occurred in that population. So it's just, again, showing that these subtle gait or balance issues that are characteristic of early preclinical dementia may actually be the root cause of the fall in the first place. So if we can recognize that close connection between falls and an underlying cognitive issue, we might be able to reframe the fall as a precursor event, and that gives us a major opportunity for early detection and intervention in dementia. Okay, next slide. I'm going to wrap this up so we have time for questions. So again, those interventions, they're just related to those internal and external factors that I just discussed. So again, it's somewhat complex dimensional because we're dealing with, and listed a few different internal factors and a few different external factors that contribute to falls and dementia. It just then demands a multi-component kind of comprehensive prevention strategy where we're looking for all of these things. Now that I'm in a hurry, I'm tripping all over my words. So then those effective intervention strategies are going to integrate these physical, environmental, and clinical management needs. So again, for physical activity, what's important, so I do fall prevention courses in the community. For older adults, our students go out and do some fall prevention classes every September. And the first thing we tell them is to stay active, because it's that vicious cycle. If we have a fall, we're scared, we stop moving because we don't have another fall, we're actually contributing to the increased risk of falling again. So we just like to emphasize how important it is that as we age, we continue to stay active, to participate in the things that we love to do. And that doesn't mean just rote exercise. Most people are like, I don't want to lift weights. That's not my thing. And that's okay. There's plenty of ways to get physical activity and exercise, so to speak, every day, just by doing the things that you love. So whether that's gardening, as Erin mentioned, going for walks, participating in maybe a local fall prevention fit and fall proof class or Tai Chi, those can all be great ways to stay active as we get older. To reduce our fall risk. So that's true of the general older adult population and true of those with dementia. It can be a little bit more of a challenge for people with dementia. So figuring out how to build those, again, talking about that cognitive reserve. Morning is a busy time, getting up, ready, having breakfast, building in those breaks after busy moments so that then we can kind of fill our tanks again before we go out and do our next thing. So get up, ready, breakfast, a break. Maybe we're just relaxing in a chair, listening to music, maybe watching news quietly for an hour. And then maybe we have some energy again, some cognitive reserve to then do something active, whether that's, taking our loved one with dementia for a walk, having them help us with activities around the house that they enjoy, but just keeping them moving. Those multi-component programs are especially good that look at both strength, balance, and cognitive motor training, like dual tasking. So that might be incorporating dual task walking, having some cognitive conversations while you're walking. One of my favorite, though, is Tai Chi. Tai Chi does an amazing job for working on balance, for ankle strategies, weight shifting, those things that we use so that when we do catch our toe on a rug and need to recover, Tai Chi gives us those, the balance, the core strength, the ankle strategies that allow us to recover. So it's got a lot of research on how effective Tai Chi can be. And it's a low impact exercise. It's usually done in a social group. It has a lot of great benefits. For activity, we recommend that you try to get at least 30 minutes 4 times a week. So about 120 minutes total per week, 2 hours. Try to spread that 2 hours over the course of the week to stay active and healthy. As far as environmental modifications, I've talked about those. Clearing clutter is number one. Securing or removing those rugs. Those rugs will get you every time, especially if you're using an assistive device like a rolling or a folding walker, a 2-wheel walker. Lighting is important so they can see where they're traveling. And then also just having some solid things to hang on to. So going up or downstairs, really important to have railings. Getting in and out of a shower or a tub, very important to have grab bars. Those are the places where we see falls that if we have something to hang on to, like a rail or a grab bar, it can have a considerable improvement in reducing falls with those things to hang on to. Clinical management, again, just a regular medication review, making sure they're not on too many of those CNS impacting medications, the opioids, the cardiovascular medications like blood pressure medications that might cause orthostatic hypotension, dizziness when you stand, and then promptly treating the acute illnesses like I mentioned, making sure we have just proper footwear on that can reduce trips and slips, and using assistive devices if needed. And I know that gets tricky In the later stages of dementia, you say, I got dad that rollator. I set it right by his door. He goes outside, he leaves it every single time. So again, it looks at that attention component. Maybe a sign, take this with you, and you go for a walk, making sure that walker is maybe their favorite color or has contrasting tape on it, something that really grabs their attention. So making things attention grabbing might increase the likelihood that they'll take their assistive devices with them when they're traveling around. But it can be a source of frustration. I do realize that if it's not attached, it sometimes will get left behind in dementia. So having someone there who might be able to remind them becomes more important with the progressing dementia. All right, and then to conclude, so we can get to some questions. The next slide. I hope I've kind of illustrated that there is a complex relationship between dementia and fall risk, a pretty direct relationship, that we need to look at both those internal and external factors that might contribute to falls and try to address those to the best of our ability using the resources that are available to us. But also remembering that falls can serve as an early indicator of impending cognitive decline. So really, just a simple change in practice where if somebody comes to the hospital, is it visits the emergency room or is admitted to the hospital after a fall with injury, that it becomes part of the protocol to just screen them for cognitive issues. Talking to them to do it. We have, especially those that are good at speaking, they can cover their dementia for, a very long time. It can be very subtle, those changes. And so just screening for cognitive changes, like something as simple as a MOCA or a SLUMS, those are the mini mental state exam. Those are all three very common cognitive assessments that could just automatically be put into the protocol for anyone who comes to the hospital after a fall with injury. And we might see that it's not just, some random incident, but that there's actually some underlying undiagnosed neurological issues that are impacting cognition and causing those falls. So recognizing that two-way street, requesting that we screen people who've had a fall, even if we don't think they have any cognitive issues, taking those in the hospital could help us catch those who might and could reduce, get the inner place that we need so that we can reduce or prevent those falls in the future. So again, just an inclusion by integrating environmental modifications, regular physical activity, vigilant clinical management, and just embracing that emerging understanding of the two-way street and falls, the need to screen for cognitive issues, underlying cognitive issues after a fall. I believe the healthcare system can really significantly improve the safety, independence, and quality of life for individuals living with dementia.
That is fantastic. Thank you, Angela. I smiled when I got your slides because you are an academic at heart. She does have, I think, 2 slides of all of her references for her presentation. So for those of you who
gotta
are,
have those.
yeah, those of you who are interested, it's all there in the copy of the slides that you can either have now or download from our website. But man, I do appreciate it. Every time I hear people speak, I pick up more and more. And this time it was a combination of things. But one thing that hit me, because I have multiple sclerosis, part of which is some executive functioning. So when you're talking about needing to do those cognitive functions and then being able to do physical things well, I went, yeah, that's me. And sometimes I will stop walking when I need to think about what I need to say, which I've noticed is different. So I've also learned in my 7 years with Commission on Aging and 5 years with Falls that everything is interrelated. And for those of you who have joined us on other seminars, you start to say, have I heard this before? We have, but from different perspectives, but it all still comes together, and the same recommendations are there, that you have to be physically active, that you have to be socially engaged, that we want to keep people safe in their own homes as long as possible. So yeah, thank you for adding the cognitive dimension to it, though, because that's something that we haven't necessarily addressed clearly before. So with that said, let's go to probably our next slide and next slide, which is working with our questions. Questions, if my voice will stay with us. We can have you put your questions into the chat, and then Michelle will kind of curate those and put together, because sometimes people have similar questions. And Michelle, do we currently have any questions?
We do not currently have any questions in the chat.
But usually when we say that, people start typing. So please feel free to start typing into chat. I did have a question for you that's kind of a higher level question, and that is, how do I know as I age or as my parents are aging, other relatives, how do I know what is just normal aging and something that we truly need to be concerned about as far as, memory loss and things like that?
Right, super important. So my students just took a test on that very question. So looking at primary aging versus secondary aging, knowing the difference between just senescence, as we call it, just as we get older, we get nearsighted, we lose some of our muscle mass. Those are just things that will impact all of us. So I'd say first and there's lots of available information online. A quick, Google search will give you some information about what primary aging, the normal aging process looks like in all of our systems, the skeletal system, vision, hearing, taste, even balance. So if you know what normal is, then you'll be able to recognize what is abnormal, those secondary signs of aging. So I'd encourage you to look up, primary signs of aging, so that when you see something that isn't one of those things, that isn't outside of the norm for the changes that occur as we age, you'll recognize that as something that probably needs to be looked at, checked out by your physician or a specialist. A good example as it relates to cognition. As we get older, what we call our crystallized intelligence remains with us. So our long-term memory, we can tell lots of great stories and relate to others about important moments in our lives. So our long-term memory is great. Our fluid intelligence, or being able to think on our feet using that working memory, our short-term memory, that declines a little bit. But we can still do most things with just a little extra time. It just takes us a little longer to process. If we are forgetting the names of our loved ones on a regular basis, or losing, misplacing things regularly, that is not a normal, the cognitive decline that we experience as we age. So again, just being able to recognize that it might take me a little longer to answer some questions or to think on my feet, but I get there. That's normal. But if I am forgetting a lot of the important aspects of my daily routines, that isn't, and I probably should have that looked at a little more closely.
So one thing that we get a lot of questions about is, sometimes I forget where I left my keys. Do I have dementia? How would you answer that
Yeah.
question?
Yeah, we have those aging stereotypes where we are convinced, and when you work with older adults in a hospital setting like I do, I see the small percentage of older adults that do end up in a hospital. And so I get kind of a skewed view of what typical aging is. But again, forgetting I have a lot on my plate most days between teaching and treating patients and going to school myself. So I do forget my keys occasionally. That's typical. It's when you're starting to forget keys and maybe a really important appointment, and maybe your best friend's name. It's kind of a larger grouping. You're seeing patterns versus just the occasional, oh, I'm a little forgetful today because I have a lot going on. You start to see patterns of moments where you're forgetting things that are kind of important to your day to day.
And I really appreciated when you were talking about if you're looking for the hairbrush and they don't remember that they could look in the bathroom as well. I think that would be I'm looking for my keys, but I'm only looking in one place. I'm not thinking about, did I leave it, somewhere else? So,
Yeah, that those search patterns become very abbreviated with dementia, so over time. So yeah, if you're seeing that typical search patterns when they do forget their keys are not there, that'd be a indicator. It could be an indicator that there might be something, some cognitive issue underlying that.
well, I know that was a loaded question, so thank you for that.
Yeah.
Michelle, do we have any questions from our attendees?
We still do not have any questions.
Well, you guys know if you don't ask any questions that I get to ask all of mine, so you better put some questions into the chat. Let's see. I did, oh, that was it, home safety. We all know that those trip and slip hazards, and you mentioned a lot of the things that people can do. And this is where I like to say, in so many situations, what we're recommending is what people should be doing to some level anyway, but brighter lights, those automated night lights that will come on so you don't trip on things in the hall, clean up the clutter, not that I need to do any of that. Many of those things are helpful, and I just wanted to take a moment to make our own sales pitch, and that is that on Wednesday, we are having full steps to preventing falls by maintaining your strength and balance, which is an abbreviated fit and fall proof. It shows how to do things both standing and seated that you can do at home. So we don't want to hear any of those excuses about, I'm not going to go to a gym, because that's okay. You don't have to go to a gym, but staying physically active is the number one thing for almost all of the things that we complain of as we get older. And then at the end of the month, we're also having our Recognize and Remove Trip Hazards at Home by Habitat for Humanity that goes room by room and tells us all the thing that we can look for and gives us some resource for resolving those. So please do take advantage of those seminars that are coming up as well. Any questions, Michelle?
Unfortunately, there is still no questions.
You guys are way too quiet. Well, Angela, is there anything else that you wanted?
No, I just appreciate the opportunity to speak with you today, and I think we got to
If
all of
not,
it. So
then
hopefully there were some tidbits in there
yeah,
that were useful.
great. Well, we are basically out of time, so that's okay. Everything worked well. I wanted to go to our next slide and just tell you that ICOA has a lot of resources. We have ADRD, respite supports, things like that in our actual programs. We have a self-paced dementia skills training that if you are the caregiver of somebody or want to know more about working and understanding people with dementia, that you can take at your own pace online. All of those resources in our content panel as well, including that conversation guide if that's of interest, and also something called the Idaho Cares program that helps people who are caregivers and support people that are working with people with dementia. So take a look at those. Next slide, please. We also, of course, have our area agencies on aging. They are your local resources for all of the programs that we offer for helps with the respite that we talked about, caregiver support, congregate meals, home delivered meals, transportation, some of the home repairs that you might need. So take a look at our website and you can find your local area agency on aging that can be of help to you. Next slide, please, is just our thank you, first of all, to all of you for being here today, because we know you're busy and we appreciate your making time to be here. Secondly, of course, to our wonderful expert, and yes, I'm going to call you an expert, presenter, Angela. And finally, to our behind the scenes person who made all of the beautiful slides run well, and that is our own Michelle. Next slide. I just want to hope that you all have a falls-free kind of day, and kind of one of our catchphrases is to say, we want you to stay falls-free in ID. Thank you all for being here, and we look forward to seeing you at another seminar soon.